Kwan Yun, you unmute. Can you hear me? I think no, we don't hear any voice. Can we just postpone a little bit and come back to you? Yeah, just because we have very short time. Abdullah Hassan not here yet? No. And then probably we can start with Prof. Rifat Atun. That will be good. From your experience, yeah, how many high income and middle income countries can mobilize funding to ensure adequacy and to ensure equity in access for many form non-communicable diseases? This is expensive, especially cancer. How can this fund cover the poor or low-income population? Do you have some example from your work? I know you've been doing a lot of in this global funding, global health. Go ahead, Prof.
Yes, thank you, Professor Hasbullah. And I'd like to extend my thanks to G20 Presidency of Indonesia and also to T20 group for inviting me. I have 2 slides, if I could have them. Yeah. And I'm going to talk about various sources of fiscal space, various sources of funding that one can mobilize to create greater fiscal space for investing in health, investing in cancer, cardiovascular disease, other NCDs and other health issues. I also want to echo what Dede Khatib Basri said today in the opening plenary. A very important takeaway message from my presentation is that when we do mobilize funds, these shouldn't be seen as a source of expenditure. Health is one of the best investments one can make. So my second slide will provide an example of a study we completed recently that shows the very substantial returns on investment when investing in cancer in low middle-income countries as well as high-income countries. So first slide, please. So the big question is, where will the money come from? Well, there are 6 different sources of financing that governments can use to expand their fiscal space for health. Of course, in addition to what I'm going to say, there's also, as Professor Hasbullah mentioned, out-of-pocket expenditure, which are highly regressive and should be pooled. There's also contributions from insurance, both social insurance and private insurance or health insurance. But I'm going to talk about government sources. I'm still waiting for the slide. If
the slide,
possible. I have no means of moving it. If someone could move the slide, please.
Not this one. This is a
well, the first source is from general revenues. So as economies grow, countries are able to generate revenues from taxation, and that can be channeled into health as well as other areas for investment. And for low-income countries or members of G20 countries, this is very important because many of the countries are growing quite rapidly, even though the Asian Development Bank recently revised its projections. In April, the projections for the Asian region was around just over 5%. In July, this was revised downwards, but it's still very substantial. In Southeast Asia, the GDP growth is for 2023 is projected at 5%. So the substantial growth. And if the economy grows 6% for 6 years, that's an additional 40% to the GDP. So if the revenues are allocated proportionately to health, the contribution from revenue growth to health budget can be very substantial. And a number of countries have been able to use economic growth to expand financing of health. And I tried to use examples from G20 countries and from the region. For example, Germany and Turkey, especially between 2003 and 2013, during the health transformation program, Turkey increased very substantially her contribution to health. The second source of financing is reprioritization of health within the government budget. So, for example, channeling funds or reducing expenditures for, say, defense and channeling this to health. For example, or from other sectors. Again, Turkey during the health transformation program prioritized health and increased investments. Mexico, during the introduction of Seguro Popular, increased contribution to health by 1 percentage points of GDP, very substantial. The third source is sector-specific domestic revenue sources. These are from earmarked or targeted taxes, such as sin taxes, tobacco, sugar-sweetened beverages. We heard today removal of subsidies from fossil fuels, or in Malaysia, for example, removal of subsidies for sugar. These can generate very substantial sums. So Philippines, for example, introduced tobacco taxation to fund universal health coverage that was very successful. In fact, very large sums were generated, and this provided an example to other countries in the region to introduce similar taxes. Philippines went on to also introduce tax on alcohol as well as sugar-sweetened beverages to raise substantial sums for the health sector. Thailand also introduced tobacco tax and channeled funding to public health intervention and for prevention. The fourth source is international finance and borrowing. For example, Argentina, another G20 member, during the pandemic mobilized funds from the World Bank to invest in health. And international financing can be also very substantial. We heard at a recent meeting in Geneva, organized by the H20 Health and Development Partnership, that green bonds, for example, increased from $3 billion to $3 trillion. Huge market. But there's no such mechanisms for health as yet. So this is something that we should discuss in terms of financing from multilateral agencies as well as from international markets. The fifth source is improving health budget effectiveness and efficiency. This is very important because if one is able to demonstrate to ministers of finance that we can improve the efficiency of the funds that we have, we can then generate a compelling case for asking for more. So we want to ensure that we're not just generating more, using more money for health, but also getting more out of the money that we have for health. And the inefficiencies in the health sector are very substantial, 20 to 40%. And by rechanneling investments from one aspect of the health budget to another aspect, one can generate very substantial improvements in what is being achieved to generate more value for money by improving effectiveness and efficiency, but also more value for many, as Professor Hazibullah was saying, by providing more to everyone, improving equity as well as responsiveness. And a number of countries have introduced mechanisms in the region to enhance efficiency. For example, Thailand, through HITAP, have invested in assessing cost-effectiveness of interventions and channeling funds to cost-effective interventions. And finally, the sixth source is innovative financing. Again, there are a number of novel instruments that one could consider: debt to health, social impact bonds. Australia and India have introduced social impact bonds. Australia for mental health, India for maternal and child health. When I was at the Global Fund, we used debt to health, conversion of debt to debt forgiveness, and using this to invest in health. And actually recently, Indonesia and Germany organized that debt to health arrangement where the Indonesian government, using the debt that was forgiven, invested in tuberculosis. That was in 2021. So there are multiple sources that can be utilized creatively to generate more funding to invest in the health sector and in cancer or cardiovascular disease or other areas. And the investments can have very substantial returns. Next slide, please. And I'll be very quick with that. A recent study we published in the Lancet Oncology as part of a commission that looked at scaling up cancer interventions across 200 countries and territories around the world. for the 11 common cancer types that account for more than 80% of the cancer burden, demonstrated that the incremental cost of scale-up of cancer treatments, chemotherapy, surgery, radiotherapy, as well as increasing diagnostics across X-ray, ultrasound, CT, MRI, PET, etc., as well as improving quality of health services, would cost $232 billion, 6.9% increase in the current cost. But the returns are very, very substantial. So the lifetime productivity gains from improvements in health amount to $2.89 trillion. And the net economic benefit is $2.66 trillion. So very substantial, producing a return of $12.4 for every dollar invested. But if you look at this map, the levels, the returns are actually far higher in Southeast Asia. I think I'm blocking the slide. If I could move. Yeah. Yes, so if you could see, the returns are far higher in Latin America and in Southeast Asia than the average. So there's a very compelling case beyond the health gains, which we're able to demonstrate, 133 million life years gain. There's a huge case to be made for investing in scaling up cancer interventions because of the economic returns. So more money, but more value for money, but also value for many.
Thank you, Prabhupada. Very clear overview of the health financing across the world. And if we look at the variation of the spending proportion to GDP, which is much better measure, instead of per capita, because the per capita can be influenced by high costs and others. We have variation. Indonesia, for public funding, only 1.7% of the GDP. The world, on average, 10%. Yeah, I'm wondering whether the 10% of GDP spent in high-income countries efficient or not efficient, adequate, too much, what? So we will discuss that later. Since I was informed that all the panelists are here, I'm going back to Guanjun. Are you there? Yeah. In China, you have urban health insurance. I think that's similar in low-middle income countries. We have public insurance, but inadequate to meet everything. What is your experience in China? Guanjun. Not still problem with the audio? Okay. Well, then let's go to Pak Susatyo. Pak Susatyo, you are in Indonesia. You know, since 8 years ago, we developed a national health insurance, the JKN. Yeah. Well, the JKN still contribute only about 0.7% of the total GDP. Very small number. But in terms of population coverage, good. There is some problem there, the indication of that. For high expensive cardiovascular cancer treatment, there are complaints that people said inadequate fund, and therefore coverage in terms of the full cost recovery to the people, yeah, to meet the healthcare needs, inadequate. In our law, we already put that to top up insurance for private insurance for those who have middle income above, who want to have a better point. As in insurance industry, what do you see this opportunity or threat of this JKN, or you can mimic what the China is doing for this?
Thank you, Professor Bola. Thank you for inviting me here to the committee of the T20. Yes, Prof, there's still a gap I can say that Indonesia government has been doing great for the people of Indonesia. We have, I can say, the best universal
you have slide
healthcare.
that you can share?
Yes, I have a slide. So can you just go to the next slide? Thank you. So basically, I can say that the government has done great job to the citizen of Indonesia. They provide us with the universal healthcare, we call it BPJS. It covers almost everyone in the country and it has been forced to be covered by everyone. Everyone need to have it, everyone need to pay for it. But the problem is, if you look at the slide, I would like to tell you that, to inform you that the BPJS Kesehatan on the below table is very, I can say, great coverage. It has inpatient, outpatients, maternity, dental, optical. Everything is covered for the premium of around $1 per month, per person, for a two-bedroom. So everything is covered. And then I would like to give you another example for the male 35, non-smoker. Let's say in Bandung, for example, just get some example in Bandung. The minimum wage is around 3.7 million or around $260 a month. Private insurance will cost you around around $30, something around that. The problem is, this is only for one person, for a private insurance. So if you want to have the luxury of private medical insurance, one bedroom with a limit of 3 billion per year, it costs you around $20 something. So total, you need to spend around 30. So the health tax, or I can say Indonesia universal healthcare costs you around $10, sorry, per month. And then you need to add an addition of that, around $30. So you have to spend around $40 per person if you want to have an adequate life and health insurance in Indonesia to close the gap. Why? Because on insurance, on the Indonesia Universal Healthcare Programs, it already cover for the radiotherapy and chemotherapy, Professor. So I can say that that is very good. But the problem is, once you go into the next level, when you need further treatment, it will not be enough. So if you look at the minimum wage in Indonesia of only around $260, how can you afford to have another treatment, which is like a targeted therapy or immunotherapies? So you need to purchase another insurance, which is the private insurance programs. The problem is we need to connect the gaps. We need to close the gaps. So that's the reason why I would say that there should be a private, public partnership on this one. Can we move to the next slide? So the cost of targeted therapy, if I'm not mistaken, correct me if I'm wrong, if I'm not mistaken, that's around 16 million, 30 million to 70 million, if I'm not mistaken, per cycle, Indonesia rupiah. So if it is immunotherapy, it will cost maybe around 100 something million. So that's around, how much is it in US dollars? Divided by 15. $10,000, something like that, yeah, Prof. So what I see in Indonesia, there should be another things that we can do between the government and also the private sectors, which is the insurance company or insurance industry. If you look at this, I divide it into the program. The program will be providing coverage for innovative cancer medical treatment, not covered by BPJS Kesehatan. This means it will cover for the innovative cancer medical treatment. It will not be limited into targeted therapy or immunotherapy. If there's any new findings or new innovations, then it will also be covered under the programs. The coverage will be covering all innovative cancer medical treatment through private insurance program with affordable premium to everyone. Meaning, insurance is about large number. Insurance is about spreading risk. So if both parties, the government and also legislative and also the insurance industry would like to work together. And the most important is pharma companies. The industry will work together, then we can find out the solutions. The problem is, if it is 1 billion, let's say 2 billion for chemotherapy, it will be very unaffordable, even for me, for example. So if you have to spend around 150,000 US dollars for a treatment, that will be very difficult for Indonesians. So there should be a working together between all industries. The parties itself, it will involve the government, insurance company, reinsurance company, that's the most important, legislative, to understand about the regulations and everything. And also the finding will be two ways. One is free for all. So it will be, I guess you're right, Prof, that it can be taken by from the sin tax or the local tax. Let's say if we want to pilot this on some areas, then we can put it from the local taxes. How it works. If, let's say, we pilot it in one province, I'm using the West Java numbers. So there are about 49 million populations of West Java. And then we do some simulations. Around 70.4 million will be on the stage 4 cancer from around, yes, and then 70,495 is person, yes.
Okay.
That will be the cancer incident in West Java, and then we will screen that into stage 4 only. That will be benefiting for the advanced cancer medical treatment. And then on the benefits itself, we would like to include the NGS testing. NGS testing is next generation sequencing, which will help the patient to get the right treatment. So they don't need to go through all tests, and then it will find difficulties on the treatment. So we already put one test there to decide which advanced medical treatment that is suitable for this person. And then for the treatment itself, again, it will be on innovative cancer care, not limited into immunotherapy and also targeted therapy. The reason why we do not want to limit that is there's new findings, I believe, in the next 1, 2, or 3 years. So if we limit it into only 2, then we have some issues. So we would like to open. Yes.
For you.
So I can conclude my presentations by saying that to have this product happen, we have to have further discussions with the government, local government, legislative, pharma industries, insurance industry, and reinsurance industry. Thank you.
Thank you, Professor Setio. Certainly, more than 100 million rupiah make me poor also. That's impoverishment. That's why we have in USC indicator, we have the indicator of catastrophic health spending, right? Spending out of pocket more than 10% of income is considered catastrophic. Right? This is what we need to avoid. Let's go back to Guan Jun. Are you there? Yes? Yeah, you are here. Okay. But we still have some problem with your audio or our audio. Let's try again. Yes. Test audio. Yeah, Pak Abdillah, also you have are you in a Zoom now? Sorry,
yes.
Okay. Guan Jun, if you are not ready yet, please test your audio again with our team here. Make sure that we can continue with you. To save time, I will call Abdillah Hassan. He is one of our activists from School of Economic and Business at the Universitas Indonesia, who've been focusing his study on sin taxes or tobacco taxes, very active, criticized the government, criticized the Minister of Health, although the Minister of Health is he's senior, right? Yes, Abdullah. What do you see potential? Is it potential for that? Prof. Rifat Atun mentioning some of the syntax we use. We have also excise tax quite a significant amount. Can you tell us a little bit?
Okay, Pak. Thank you. Sorry for it. So in this occasion, I will share about the current use of health tax to fund the health deficit on the current one. So we have a current, what we call it, maybe it's a quasi-earmarking health tax. Actually, it is like a local government earmarking for the local government. That is potential for cancer treatment. So we have two mechanisms. The first is from the 3% tobacco excise revenue sharing for local government unit. This is from the mandate of the excise law. Excise Law 39 2007, and also from the Ministry of Finance Regulation 215 2021, and also the second mechanism is the 50% local tobacco tax for health, the mandate from the Undang-Undang the Law 28 2009, and also with the MOH regulation number 40 2016. Regarding the 3% tobacco excise revenue sharing for the local government unit, so from the excise good, we have three excise goods: tobacco product, ethyl alcohol, and alcoholic beverage. So these three products is excise to control the consumption. And then from the revenue, from the tobacco excise revenue, 97% is for national budget. And then the 3% is for revenue sharing to the LGU. So this is the fund, the revenue from the central government shared to the local government in Indonesia based on their tobacco or cigarette production. And then of the 3% revenue sharing to the local government unit, 40% is for health, 50% is for social welfare for farmers and workers, and 10% for law enforcement in illicit cigarette. So we are focusing on the 40% for health. The 40% for health is the guideline, the detail of this use is in the Peraturan Menteri Keuangan, Ministry of Finance Regulation 215/2021. It is stated that this 40% can be used for public service in terms of health, can be used for public service to decrease stunting prevalence, COVID-19, increasing vaccination and immunization, child and mother health, and lung and respiratory diseases. And also the second one, it is used, can be used for provision for health equipment and infrastructure. And I think we can use it for cancer treatment. But this fund is in the, little bit like the central government and local government authority. And then the third one is provision for sanitation, waste management, and water, and also for the CKN premium payment by the local government, including for layoff workers. And in the Ministry of Health in 2016, there is a local cigarette tax for health, based on law 28 2009. Since January 1 2014, the local cigarette tax is implemented, and then the tariff is 10% of the excise tariff, and then this distributed to all province by population. So more population gets bigger or higher this one, local tax, and then 50% is earmarked for health and law enforcement. In 2016, MOH issued a guideline to use it for public health under the Permenkes Ministry of Health Regulation 40/2016, intentionally for health promotion. However, in 2017, there's a situation where the government decided to use 75% of this local cigarette tax for health to pay the JKN premium contribution. So 37.5% in total. But still, there are 12.5% of this one can be used for health. Other purposes, including for cancer treatment. And this is a big money, yeah, big funding, because the potential revenue of this is around 10% of the excise revenue. So if the excise revenue is 170 something trillion, so the potential of this local tax is around 18 trillion. So 50% or 12%, 12.5% of this 18 trillion can be used for health, and maybe we can use it for cancer treatment. So under the Permenkes 40/2016 in the appendix, there's an explicit statement that it can be used to fund cancer early detection equipment. So alat deteksi dini, early detection for cancer risk detection for breast cancer and for the age of 30 until 50, and then early detection for children cancer and for the
Thank you, Pak.
follow-up
We can
treatment.
share the document.
And however, that was
Hello?
the current practices. So the current
Pak Abdillah.
practices is earmarking of
Pak
the
Abdillah,
central
you run out of
government
time,
funding
Pak
to the
Abdillah.
local government, but in that situation, there is a mandate to use for health. However,
Okay.
this is not, I think, this is not ideal. So in the future, we should propose earmarking, dedicated earmarking for the universal healthcare for the JKN. So first, we have to enlarge, or we have to add
Thank you, Pak Abdillah.
additional goods to be excised, to be like sugar sweetened beverage, maybe fat
Hello.
sources,
Yeah.
and other kind of unhealthy food. And then we can earmark 10% for JKN. And then
Okay.
third, we have to amend the required law.
Thank
Okay,
you.
Prof, that's all for me.
Thank you very much. Sorry for being a little bit rude because we want to make a fair share for everyone to talk. Back to you, Dr. Kwan Jun. Are you there now? Is that fixed? The audio? Otherwise, I will move forward. Yeah. No answer. Yeah. Okay. Yeah. If no answer, then we can move forward. Just for information for everybody, this year our government received close to 200 trillion rupiah from cigarette excise. But the government budget for healthcare to the Ministry of Health and others is only 130 outside the COVID. So more money from the cigarette excise, but only 10% for that. Yes, while waiting for Kwan Jun to fix that, I'm going to go to this 2% here, ready to fight or debate or discuss the presentation. Yes, Dr. Krishna and Dr. Adhyatma, you there, Dr. Adhyatma. You are the Adhyatma in Bandung. This, if we're talking about a cancer, and we do have in Indonesia the STA Commission, Technology Assessment. Yeah. But the guideline of the WHO limit the threshold 3 times GDP. Well, 3 times GDP in the US or in the UK, that's quite high. For Indonesia, 3 times GDP, and the price of cancer medication is still following the international price. What is your opinion about that for us in low middle income countries?
Yeah, I think that was one of the points I wanted to comment in terms of while the various methods of raising finances to fund advanced care, whether it's cancer care or cardiac care, it's a lifetime care and advanced care. Given the fiscal limits of every country, and also the political capital which influences the policies on taxations, extra taxations. Other innovation that can be looked at is from innovative development. Ultimately, the cost of advanced cancer care translates into cost of care to the patient care. As we have seen during the COVID pandemic, where the concept of global public goods, that means pooling of resources from the time of innovation itself, not at the end product financing. So if there is an innovation at a financing at an innovation level, a pooled financing at an innovation level, so that you have protected the intellectual property of that innovation for the global public good, that may have actually manifold return on the investment than investing into advanced cancer care where the price restriction is not there. So that's, I think, one of the area that can be looked at. I think globally we are looking at in terms of how do we produce the global public goods. It's not to discourage innovation from the private sector, but at the same time to protect those unprotected people. How do we pool that? So that's, I think, one comment in terms of the second thing is, I think there was a lot of talk in the policy brief as well in terms of the regional collaboration where I think the Africa Union is demonstrating how countries can pool together their expertise, their knowledge in funding the innovation itself. Okay. The second element in terms of, I agree on the fifth comment, I think that is the most relevant from the developing world, especially in the context of limited fiscal space. There is so many other things are equally pressing as cancer treatment. So in a given limited fiscal space, I mean, from an Indian context, I can spell out that there is 20 to 40% of budgeted public finance is not spent. Oh. We just unlock that. It does not require too much money to improve that efficiency there. And another point which is relevant not only for the developing world but also to the developed world is what is the cost of low value care. That means the care that is not needed. We are giving a lot of not needed care because of fee-for-service system of payments, whether it's insurance or whatever method. So when you have an incentive for providing more services, in the current regime of fee-for-service system, then what is the incentive for that? I mean, how do we contain that cost by looking at a disease cycle approach in the sense that if we have a national program, whether it's provided by private healthcare or public healthcare, but that looks into an entire life cycle of the cancer disease, right from the prevention to early detection to advanced care to, because at an individual level, nobody wants to be denied advances in technology. Whatever we talk at a population level, at individual level, nobody wants to be denied. So while we prioritize on the preventive side, there is also need to ensure that as an individual, everybody has equal right to access advances in medical care. So that is where if we can de-risk the load on advanced cancer therapies across the population involved in the disease of cancer or disease of heart disease. So these are the two thoughts I thought I will add to the discussion point with reference to, in addition to the innovative financing and innovative insurance methods.
Thank you, Dr. Reddy. So innovative financing doesn't mean just mobilize and pulling money, but also controlling spending. That's important. Let's hear from Kwan Jun. I see I got a notification that you are ready. Maybe you- Okay.
Can you hear me now?
Yeah, yes, good.
Sorry.
Finally, okay. Yeah.
Yeah. Sorry.
What is your experience in China? Yeah.
Yeah. Certainly, there's a gap between two different systems, and it takes some time to get used to it. Thank you for the opportunity to share our view on an innovative healthcare financing solution in China. It's called Open Customized Commercial Medical Insurance. It's an emerging public-private partnership scheme that improves medical protection in China. Actually, I do have 2 slides. Can someone try to share the slides? Okay. For the people who are not familiar with China healthcare financing system, please allow me to briefly introduce our multi-level of financing structure. On the bottom, we have social health insurance, or called SHI, providing basic medical coverage. On the top, we have private medical insurance with rich benefits, covering around 300 million people out of 1.4 billion people in China. So majority of the population is protected by SHI only. Not hard to imagine, in a big country like China, the protection of SHI remains limited, though governments have put a lot of efforts into healthcare. For example, drugs will be limited to national reimbursement drug list. Innovative drugs and treatments, such as specialty drugs for immunotherapy, are usually borne by patients themselves. If we look at the big numbers, around 60% of total medical expense are covered by SHI, leaving 40% to be paid by patients themselves or through private health insurance, which contribute to about 5%. The percentage of out-of-pocket expense is even higher for specialty drugs, and the affordability is an even more serious concern for majority of the population in China. UCCMI is an extra layer of protection staying between the social health insurance and traditional private health insurance. The emergence of UCCMI has greatly improved the situation and lowered medical cost burden for patients as a feasible alternative solution. Common coverage includes inpatient medical reimbursement. It usually have a high deductible of US dollar, like 3,000, and it has high limit of 150K US dollar to cover complicated and expensive surgeries. UCCMI scheme is also considered as option of providing equitable access to new cancer treatment. Most UCCMI programs also cover specialty drugs, in addition to inpatient medical expense, with 15 to 25 tumor-targeted drugs, immunotherapy drugs, or orphan drugs that are not yet covered by SHI yet. The customized drug list usually cover several types of indications, including lung cancer, leukemia, lymphoma, breast cancer, prostate cancers, etc. Let's look back at the history of UCCMI. Could you move to the next slide, please? It has developed quite quickly since 2020 with concerted efforts of government entities, insurers, online platforms, and other TPAs. By the end of 2021, more than 120 cities in 28 provinces has launched UCCMI programs. It totally cover 140 million, which is about 10% of the population in China, which is a great success considering that this scheme is only launched 3 years ago. Several factors have contributed to the success of UCCMI program in China, including national and provincial regulatory support. More than 10 regulations have been released to guide the development of UCCMI in the past 2 or 3 years. In addition to the regulatory support, we have observed that local guidance on program implementation is also critical. There have been program implementation plans released by local bureaus to guide, coordinate, and/or supervise program implementation. As public authorities, local bureaus tend to provide guidance on product design, such as insurance coverage, deductible, limit, and co-insurance. They also provide guidance on financing approach, program promotion, provider selection, etc. With the regulatory support and implementation guidance, the actual involvement and support of local bureau also have a large impact on UCCMI penetration ratio and program sustainability. It has been observed that programs penetration ratio are generally much higher in the cities with earlier involvement of government and a strong promotional support from local governments. Authorization to pay premium from SHI personal account is also another key success factor. Those cities with access to SHI personal accounts with a 3 times higher loss ratio, penetration ratio. UCCMI program in Shanghai is a great success. It managed to enroll 40% of the population in 2021, which is around 74 million people. With Shanghai local bureau's support and involvement from the very beginning, out of that US dollar 120 million premium, almost 90% will be paid out as claims, which is unimaginable for any other private health insurance. Claimants ranged from age 1 to age 104, with those aged 66 and above as the main beneficiary, consisting of 45% of all claimants. Shanghai government has also been active helping promote insurance and educate people of insurance, both UCCMI and other private health insurance through apps or online platforms. 74% of UCCMI survey respondents indicated that their health protection awareness has been raised and that they're willing to purchase additional health insurance such as critical illness. Overall, with continuous support, guidance, and supervision from government entities, UCCMI scheme in China is expected to be a feasible healthcare financing solution. More importantly, we think it's an effective way of increasing the insurance awareness of the general public with endorsement of different levels of government. Hopefully, my sharing today can shed some light on the implementation of a similar healthcare financing scheme in other countries in this region. Thanks.
Before we continue, I think I'm boring with this man voice. I want to call woman voice. Dr. Dr. Yuli, are you there? Hello?
Yes, Pak.
Okay, thank you very much. Dr. Julia Parianti is the head of the Center for Health Financing Policy and Decentralization of the Ministry of Health. She has a good decision making on this health financing issue. Dr. Yuli, what has been done with Indonesian using this innovative financing? What can you share to us?
Repeat, Pak.
What
the
can, yeah,
is not good here.
Okay, so we are discussing about innovative financing because our constitution said everyone has the right to health care. And we mobilize health fund through JKN, but still very low compared to the needs. And some of the poor people already subsidized great with the government, but still inadequate. And the government has money of the excise, yeah, the cukai rokok, pajak rokok. How do you formulate that, and what is the experience of the use of this? In the Western country, they call it sin tax, but Indonesia might not understand sin, so they don't say sin tax, yeah, but the pajak rokok. Go ahead.
Ya, Pak. Thank you so much, Pak Prof. Hasbullah, and all the participants and the panelists. I want to share some, I think this is our Abdillah. She helped me to, I think we can call this transformation for the text. I think Pak Abdillah, as mentioned, Pak Abdillah said, there are 3 tax object product, ya Pak, namely ethyl alcohol, alcoholic beverage, tobacco product. In 2021, the Directorate of Customs and Excise reported that 60% of the tax allocated for the health come from the tobacco product, exists, and its value has increased every year. But in 2022, the government, through the Ministry of Finance, determines an increase excise by an average of 12%. This policy is one of the government effort to improve the quality of human resource in Indonesia. With this increase, the government expects to control cigarette consumption in the community, especially among children and adolescents, as well as avoid the bad effect of the cigarette society. And the other, Prof. Hasbullah, now we want to arrange about the I think Pak Abdillah will have still develop regulation for the undang-undang yang Pak Abdillah is not finished. But our minister is very committed with it, and we still push for the governance to what else to decrease for the consumption and the increasing to for the tax for the tobacco. This is our reform, Prof. Hasbullah, and the others. We start not only tobacco, but for the sugar, beverage, and the others. It is why it is the first I comment Prof. Hasbullah. Prof, I'm not here. Hello.
Yeah,
Yes,
thank you. Hopefully, the government succeed with mobilizing more money through other taxes like sugar and beverage, as you mentioned. But that's in theory. We want to hear from the field. Yeah, Dr. Diaz from University of Gajah Mada has been doing studies on this, the use of syntax. What is the experience that you can share with us?
Yeah, thank you, Prof. Hasbullah, and all the committee that I'm invited in this Indonesian Summit T20. So I would like to highlight first your first comment on the underfunded for the achievement of our UHC. So you are right that we have around, let's say, 2% of the GDP. Our GDP is low, and then the percentage is also lower. So this is like an ad of cigarette. How low can you go? So it's yeah, for me, it will picturing the commitment of the government on health. And I agree also from Prof. Rifat that already mentioned about sector-specific revenue, that this is the way we are trying to search other resources that could fund it, funding the health sectors. So the tobacco tax is one of the options that from my study with our team from UGM, we found that this is the potential resources. We know that but in the other hand, the changes of the commitment itself is also unstable from my point of view. We could see in the beginning of 2020 that the proportions for health is around 50% from the tax for health. And then less than 1 year, the regulation is changed. it's changed to 25% goes to health. So it's half. Then in the earlier 2021st, thanks God, it's getting higher, 40% for health. So this is what we are saying, that the commitment should be there. So the proportions funding for health should be seen as investment, like what you have presented before, that allocate more fund in health. That is the beginning of the development of a nation. So that is why tobacco tax could be seen as a potential resources. How about the field they are using this tobacco tax? We found variations in the field. It depends on the how innovative the local government is. So for those who has more fund and more innovative ones, they could even build one hospital for lung. So it's a lung hospital. They use part of the tobacco tax to fund these infrastructures. But for those who are not eager enough to use this tobacco tax, then it's a different story. So we have to build at least one manual guideline on how to use this huge money. So it can be more effective, like you said, that efficiency and more effective. So not only raising the fund, but to monitor how to use and allocate this, to whom, who is the beneficiaries, and it can be also funded or help the aim of overall. And the other challenges, Prof. Hasbullah, is the technology itself. Because the rapid development of technology, I think this is also another challenge, that the system, the scheme, the insurance schemes cannot afford all the new technology. It has to be approved first by the HTA team. But let's see how many HTA tests or evaluations can be approved in a year. So this is also the limitations of the mechanism of health technology approvement.
Thank you, Dr. Dia. Yeah, certainly more research, more studies need to be done to get big applause for Dr. Dia. Now I'm going to Dr. Nina. Are you there, Dr. Nina? The
Yes, I'm here, Prof.
Okay,
Yeah.
thank you, Dr. Nina, for joining. A lot of discussion on this innovative financing for healthcare, coming discussion of the sin tax or excise tax. You in the province level has the right to 10% of total excise for health, yeah, for excise tax. What is your experience, and how ready are you if we are doing some kind of piloting in your province, which is a big province, 50 million people, larger than many European countries. Yeah.
Yes.
How far do you think? Do you see this is a potential and improve access and help you to finance some of the healthcare problem for your people there?
Yeah. Thanks, Prof, and all participants. Yes, my province is the most population, almost 50 million population. We have innovation in health financing, especially for cancer care, Prof, based on the 4 health efforts approach. Can you hear me, Prof? Yes. Yeah. First, in promotive efforts start from outreach to the community, and then continue with early detection carried out with a networking community organizations such as Leukemia Foundation, Indonesian Cancer Foundation, Indonesian Child Cancer Foundation, and UNAIDS. And then in preventive, we have a program, PUSPA program, Prof. PUSPA program is the Integrated and Champion Health Center program. Prepare trained health workers to improve the performance of health centers in the field of COVID-19, nutrition, and non-communicable disease cancer, such as cancer, diabetes, hypertension, and carried out in 100 health centers and in 12 districts or cities. And then the PUSPA program also help improve the performance of Puskesmas in education and reporting on cancer data. And early detection of cervical cancer through EVA test and detection of breast cancer through Sadanist examination has been carried out by all Puskesmas. And curative, the extent of health facilities as an integrated cancer reference in several West Java Hospital, I mean, including Al Ihsan Hospital, Hasan Sadikin Hospital, Santos Hospital, Walid Hospital, and the Ministry of Health, in this case, has helped prepare superior cancer service, including the Bandung Kiwari Hospital and Gunung Jati Hospital. The establishment of a halfway house or stopover the service as a shelter for patients who will undergo cancer treatment, especially out-of-town patients, such as Seruni, Rengganis, Yayasan Kasih Anak Cancer Indonesia, or YKKI. Establishment of nursing centers in Puskesmas, in districts or cities. At least one center is a center of nursing, education, and research services. For example, bone care for patients with breast cancer. And construction for or of special hospital for lungs of Karawang by utilizing the tax and tobacco revenue sharing fund. And rehabilitation, we have Hasan Sadikin with a palliative team. So the president of palliative team care in Hasan Sadikin. And then about the health tax, Prof. The innovation of the health sector we use tobacco tax. We call DBHCT for tobacco tax. Yeah, utilization of DBHCT at health office is in accordance with the Ministry of Home Affairs Regulation of 2020 for procurement of health service facilities, provision of instructor in health service facilitation, construction of hospital and their sporting facilities instructor, construction of health center, hospital development like in Karawang, and then rehabilitation and maintenance of Puskesmas, procurement and maintenance of calibration tools, improvement of quality and health facility service, and procurement of maintenance medical device and medical support equipment for health service facilities, and then utilization of DHBCT in health laboratory or hospital is used procure medical device at laboratory and hospital, and utilization of DHBCT in regency of city, almost all district or cities using DHBCT for procurement of vaccine storage or cold chain and DHBCT for the payment of the poor health financing or PBI due to insufficient district or local review. That's they use DBHCT too. And then for the last 3 years, it has been used for COVID financing and poor financing, and 50% of the DHBC has been used for the health sector. That's all of my
Nina, hopefully you can get improvement with more ideas and more money coming to West Java province. Last comment before we have a photo session, please. Those who you who are in the Zoom, please stay for another 10 minutes because we want to finalize and get a picture of together. Dr. Adiatma, from the School of Business and Economic of Business, Pajajaran Universities. You are in the West Java province. How do you see that ideas of getting pilot in West Java, and you can give us ideas, challenge, and opportunity for that? Can you share with us in 5 minutes?
Okay, thank you, Pak Hasbullah. Can you hear my voice?
Yes, clear.
Okay, thank you. I'll be quick, Pak Hasbullah, because I hope you're not blinded by the light emanating from my forehead. I'll be quick. Dr. Lina has mentioned about the two innovatives. Actually, it's two. It's Puspa and Prima. And both of them are actually a new approach by enhancing the role of primary healthcare. So we are currently evaluating Prima, so that's still ongoing. But for Puspa, I think it has the potential to have value for money, a good value for money, because then by applying the approach, you can actually, in this case, it's about COVID. You can detect more patients. You can have more. You can detect more patients. You can have more patients on treatment, etc. So these innovations are actually what we need. But that's in terms of treatment and public health. But of course, if you are talking about funding cancer, then that's another story. I mean, we hear a lot about the syntax. I mean, syntax is great, but then we may need to ask ourselves about its sustainability, because and in the short run, I think it runs great. But in the long run, because syntax, it's basically later on we would like quote unquote the sinner to reduce their let's say tobacco consumption, and when they have reduced the consumption, then there's the question whether the syntax can cover cancer treatments or research. Now another thing, Pak Hasbullah, that I would like to add is, I think you mentioned this, Pak Krishna also mentioned this about the efficiency and effectiveness. I remember I read about Pak Amartya Sen, who wrote that the country can be healthy if they use their resource in the socially productive way. So despite its poor conditions, so I think that's very important. And it comes back to us whether, in this case, Indonesia, have we spent our resources in a socially productive way? If we can somehow, detect those inefficiencies, maybe we can find some room in terms of fiscal space. So we may not need that much of innovative financing, but we just need to use what we have efficiently. So so there might be my 2 points, Pak Hasbullah: efficiency and effectiveness of our current use of budget, and also the sustainability of innovative financing for cancer. Thank you, Pak Hasbullah. Pak Hasbullah, I cannot hear you. Apologize.
You hear me?
Yes, thank you. Yeah.
Okay, yeah, great, thank you. Hopefully you can help us in later mobilizing and making more efficient funding in West Java. Ladies and gentlemen, here and over somewhere, I'm sorry I have to use my privilege as moderator. I will be taking discrimination. I'm going to ask two persons to give some final comment. First, Professor Rifat Aton, and second, Dr. Guan Jun. Professor Rifat, what is your comment after listening, hearing of this discussion in the last 1 hour and 20 minutes? Just 2 minutes. Yeah, sorry, I cannot give you more time.
No, 2 minutes is 2 minutes is plenty, and thank you. And really excellent contributions from my fellow panelists and discussants. I have 3 comments to make. First of all, one has to take a step back and look at the epidemiological transition that Indonesia and countries in Asia are undergoing. This is happening very, very rapidly. Whereas Western countries had 100+ years to adjust their health systems to these transitions, countries in Southeast Asia, including Latin America, do not have that luxury. The cancer burden is going to increase fairly rapidly because of also the demographic transition that you're undergoing. So that brings me to the second point, innovation. Because of this transition, you cannot follow the same trajectory as European or Western countries. And you cannot also leapfrog, because leapfrog would just leap you onto the same trajectory. You have to create a new trajectory. That brings me to the second point, which is innovation. I strongly agree. One should explore all the potential sources of financing in relation to fiscal space, but think about innovating, both in generation of new sources of financing, but also very importantly, using innovative ways of using these finances. Again, drawing on new technologies and innovations, including investment in digital. Really try and recreate the health system to achieve value for money, but also value for many by improving effectiveness, efficiency, equity, and responsiveness to the citizen expectations and to the changing needs. That brings me to the third point, which is this should be done in an inclusive way. Hatice Küçük, in the meeting we had a couple of days ago in Geneva, said it's health for all, but also health with all. So I think this will come through strategic public-private partnerships that actually is very inclusive and brings everyone on board. I'm using the adjective strategic public-private partnerships because PPPs have a fairly bad name. The strategic PPPs are at scale, and they're not for pilots. I really don't like the word pilot. I have an allergy to it. I would call these demonstration programs.
Okay.
Really implement and learn. Cancer is not going away, nor are these challenges. Cardiovascular disease is not going away. So demonstrate what can be done, learn from them, and extend them. So think about the transition that's happening, move to a new trajectory, create the new trajectory. Secondly, innovation, and third, strategic public-private partnerships.
Thank you, Professor Atun. A big applause. Now I'm going to go to ask Dr. Guan Jun. You are ahead of us in terms of implementing or demonstrating this supplemental medical insurance. Maybe you can give tips for us in Indonesia and maybe also in India and South Africa, middle income countries there, and Brazil also that would like to go to that direction. Dr. Guan Jun?
Okay, certainly.
Yeah.
Actually, for the program, we piloted in China. The average premium is like $10 to 20. So it's really a small amount of money to cover the general public, including those in rural area. While we are trying to learn from Western countries, I certainly believe that people in this country, in this region, share more similarity. We kind of have the same challenge to deal with. We cannot spend like over 15% of the GDP with healthcare. With limited budget, how we can make a good use of it, whether it's from public resource or private resource, how we can use that money smartly to cover more people is certainly the common challenge we need to deal with in this region and also in some other regions. We would benefit from learning from each other, and it's good to have this kind of discussion over time to share and to learn from each other. Thank you.
Thank you, Dr. Kwan Chun. It's almost time that the organizing committee give me for this session. I will not make a conclusion or any comment. That will be enough. Please, our colleagues in the Zoom, stay in that. We will have some photo picture. Unfortunately, we have to be kicked out from our chair. We have to stand. Yeah, go ahead. Take the chair. Yeah. Yeah, move the chair. So, because they said it's not good enough if there is chair. We have to stand here. Yeah. Okay. Yeah. Bisa angkat? Yeah. This is Indonesian style. Take a picture after this. By the way, I think organizing committee, please let us all know where is the access for the YouTube, whatever recording that we can share to anybody. So who will be? Oh, okay. 3% there?
Oh, let me move there.
Okay. Okay. So please keep in mind that we are responsible for this, all of us, panelists and also discussion. Okay. Take a picture. Good one, yeah? Bu Yuli, are you there? Yeah? Okay. Smile. So, which camera we are looking for? Make yeah, otherwise we will look not in the right. Okay. 2, 3. Okay. Thank you very much for all of you who are here, panelists, discussion, and all participants here or in the Zoom. Yeah. Thank you. Hopefully, it's great progress for us after this the 20 meeting. Thank you. I return this time and screen to organizing committee. Thank you very much. Siapa yang mau ngambil foto?
Recording stopped.